Good afternoon, everyone, and welcome to this session on redefining human resources for health from the laboratory to the last mile. My name is Anthony Gitau, and I'm honored to have the pleasure to moderate this panel. I am the Director for Global Community Impact at Johnson & Johnson, based in Kenya, looking after the work that we do in East and Western Africa. Now, today is quite a special day for me. My son today turns 18. And as he turns 18, I start asking myself questions in terms of how I've prepared him for the world. And if we look at 2020, which was the year just before he turns 18, as a parent, you start to ask yourself, are you really ready to protect your family against pandemics and the dangers that come? And for children, they look at you as the protector. You are supposed to protect them. And in the last year, as a parent, I felt that I was not able to do that which my family expects me to, because I could not fight this unseen enemy. And therefore you really wonder whether you are ready for this challenge when it comes. But then when I thought about this panel, it even became more challenging for me if I considered what a frontline health worker went through in that year. While we had to stay home, they had to go to those places where we avoided to go. And you need to have a health workforce that is really committed, that is really prepared to be able to face such a challenging situation. And once more, I take this opportunity to take our hats off to all the frontline health workers that have stood up to protect the world against the COVID-19 pandemic, and we salute you. But today we really want to look at how can we redefine human resources for health, right from research in the laboratory to the last mile where we're engaging with the patients at the community level. And if anything, this pandemic has shown us that health systems strengthening cannot be the task of only one organization, Ministry of Health, government, but it is the work of all of us. And the only way out of this pandemic and to restoring strong primary health care and pandemic preparedness is through the people of our health system. And it's through all of us working for all of them. And I really like the way that is phrased, all of us working for all of them. And they have worked for us in this instance, and it's really our turn to make sure that we work for them to ensure that in the future they're better prepared for normal times, but also for pandemic times. And the them we're talking about is really from nurses, community health workers, data scientists, entrepreneurs, everyone who's working in the healthcare continuum. And our role as stakeholders is to see how we can really ignite that ingenuity and bring out that capacity that they have in them to ensure that we really can make a difference for health services, especially in sub-Saharan Africa. Our panel discussion today will demonstrate how capacity building at every level of health is redefining human resources for health beyond COVID-19, because we know we'll be past this pandemic. And it's really up to us to prepare very well to ensure that the next pandemic doesn't impact us as much as this one has. Our valued partners on the panel will speak to the work being done with technologists, nurses, researchers, practitioners to advance the leadership skills and talent across all of Africa to solve the challenges ahead in our health system. It's now my pleasure to introduce my very esteemed panel, who I would like to really thank for taking time to agree to have this discussion with us and really share a light on this. The first is Dr. Brenda Okware. Dr. Brenda Okware is a medical doctor with specialization in public health and a focus on infectious disease research. She has spent most of her professional life in clinical research execution in sub-Saharan Africa, having served in roles of trial coordinator and investigator in Uganda. She was also the inaugural fellow for the Johnson & Johnson Global Public Health research and development capacity building program, where she contributed in the TB pediatric strategy supporting the clinical team. The second is Kwame Tete from Medical and Surgical Skills Institute, Ghana. And Kwame is a leading medical training and policy executive in West Africa. He is the executive director of the MSSI in Ghana. MSSI was set up in 2005 in partnership with J&J and the West Africa College of Surgeons. Under his leadership, the MSSI has become the leading training center in West Africa and has grown from 18 annual participants to more than 33,000 participants in 2020. Our third panelist is Eunice Palangio, who is the Associate Professor and Academic Head of Aga Khan University School of Nursing and Midwifery, Tanzania. Dr. Palangio holds a PhD in medical sciences, focusing maternal and child health from Uppsala University in Sweden, and as well as a Master of Science in Nursing qualification from University of Cape Town, South Africa. She is well experienced in mixed methods research in rural and urban sites in hard-to-reach communities involving women and healthcare providers. Our fourth speaker is Dr. Betty Marembe, the Country Director of Mothers to Mothers in Uganda. Dr. Betty is a medical doctor with postgraduate training in public health. She leads Mothers to Mothers work in Uganda, including managing a team of around 100 women living with HIV who serve as community health workers called Mentor Mothers. Our final panelist is Caitlin Law, who is a digital health technical advisor for IntraHealth International. Caitlin is a Fulbright scholar and received her master's degree at Royal Holloway University of London. Her experience spans digital tools and approaches, including interactive radio programming, peer education and outreach, e-learning and human-centered design. For the past 1 year, she has been the product manager for mHero, coordinating software development and country implementations. She also supports many other digital activities and components of IntraHealth activities in Francophone West Africa. So welcome to my dear panelists, and I really look forward to this conversation. So just to kick us off, I'd like to ask, starting with Dr. Brenda Okware, maybe you can say a little more on what you are doing in this area of redefining human resources from the laboratory to the last mile.
All right, thank you, Anthony. Good afternoon, everyone. It's indeed an honor to be part of this panel this afternoon, especially considering that I recently completed a capacity development fellowship as well. So my name, just mentioned before, is Brenda Okware. I'm a medical doctor from Uganda and a clinical researcher. Right now, I work with Johnson & Johnson Global Public Health R&D, and this is an organization that seeks to deliver innovations in health to underserved populations with high unmet medical need. So the disease areas are characteristic of populations that might be restricted in certain areas, especially resources. So the disease areas include things like TB, soil transmitted helminths, dengue, as well as mental health, to mention but a few. So my work right now is attached to the capacity development group, where we're looking at developing an operational model for carrying out quality clinical research in areas that might have resources constrained. And this will take into account some of the challenges that are specific for these areas, but also look at opportunities as well as unique characteristics that might come into play by virtue of such a context. I also work on an initiative which is still in its early stages, that is a cross-farmer capacity development initiative that is bringing together various industry partners, African players, key research stakeholders such as the investigators, the regulators, and different sites to, first of all, identify gaps which can be translated into avenues for growth, but also to seek the creation of an environment where there is mutual benefit for all who are involved, as well as providing a platform to showcase different capabilities and capacities. So all these initiatives in the long run will seek to address the disparity or the disproportion in the volume of clinical research that is right now being carried out on the African continent. If you look at it in the wider context, it's only 2% of the global proportion of clinical research. And this is quite disappointing if you compare it to the actual burden of disease on the African continent. So in the long term, the overall goal will be to bring more clinical research to the continent, to strengthen collaborations, to build on knowledge and skill within the continent itself, create centers of excellence in research, and also allow scientists from the region to contribute towards developing evidence-based solutions to the hurdles in healthcare in Africa. So that's what I'm involved in right now. Exciting and yes. Thank you, Anthony.
Thank you, Dr. Okware. And I was informed that your surname means the night, if I'm not wrong, in Uganda.
That is so true, but I'm a child of the sun, so I never do darkness so well. So I love the sun, but that is true. My name does mean born in the night.
Excellent. Thank you, Dr. Brenda. Dr. Kwame, MSSI has grown so fast over a very short time and is really generating huge numbers of frontline health workers reached with training. Can you tell us a little more about that?
Okay, Anthony, I also want to thank you for inviting me to be part of the panel today. The MSSI, I would say, it's now the leading training center in West Africa. We were set up primarily to provide in-person, hands-on training to health professionals. MSSI, I would say, is committed to providing the best available medical and surgical training and technology to advance healthcare in Africa. MSSI, as you said, was established in 2005 as a partnership between Johnson & Johnson and the West African College of Surgeons. It was created to teach just one course, which is the ATOM course, Advanced Trauma Operative Management. The course content was having didactic sessions where surgeons had their skills improved on how to manage injuries that have been inflicted in the abdomen and cardiac area of patients. So basically what we do during that course is to inflict about 56 different injuries in the abdomen and cardiac area of dummies and train our surgeons with hands-on training as to how to identify all of these injuries and fix them within a period of 3 hours. MSSI, I would say, was the first place the ATOM course was allowed to be taught outside the USA. During the first 5 years of MSSI, we only focused on running this surgical course. However, in 2009, we decided to expand our scope of training and included all categories of medical professionals: surgeons, still anesthesiologists, physicians, nurses, midwives, lab technicians, community health, and even hospital administrators. I would say we also, beyond that, started expanding our geographical scope. And as I speak now, we have provided training programs to about 13 different countries in West Africa. We have now grown to become a world-class training center, which is a center of excellence in health. In 2019, as you said earlier on, MSSI trained 9,847 different categories of health professionals, and our research and follow-up showed us that it benefited 18.6 million different patients from all over West Africa. Last year, as a result of the COVID-19 pandemic, we decided to add online training programs to our courses we run. And as a result of the online training programs we added last year, we were able to train 33,000 over 33,000 medical professionals across Africa, and we had several other health professionals in South America and other parts of the world logging on. So for now, I'll end here, so we continue later.
Thank you, Kwame, and that's just really amazing numbers. And just because you've touched on the issue of digital, I'd just like to jump to Caitlin and ask Caitlin the work that she's been doing around digital and how she sees this as a key part of capacity building.
Sure. Thank you, Anthony. And thank you to the previous panelists who have introduced themselves. My name is Caitlin Blair, and as was said in the introduction, I'm a digital health technical advisor. And for me, digital health is pretty broad. And so it's not necessarily using the most sophisticated technology, but rather using the technology that people already have and that they already use. And I do support a variety of different digital activities. Primarily, I am the product manager for mHero, which is a tool that has been supported by Johnson & Johnson. And it connects ministries of health with frontline health workers and facilitates communication between those two ends of the health system. And it does this by connecting health information systems, particularly the human resources information system. So we're able to gather contact information for health workers, but also understand what their role is, where they're based, and different kind of characteristics so that we can send them kind of targeted communication as well as just broad communication as well. And to really get any kind of information down to the level closest to the general population. So this can take the form of if we're thinking about capacity building, it can take the form of refresher messages, knowledge checks, quizzes. It can look like and I think one of the most important things is that the digital content, it doesn't need to be kind of elaborate. It can be basic checking in, basic messages that provide information clarification on, especially as we've seen with COVID, new science that's out there that we need to communicate that information to the general public. And I think that the community health workers and health workers in general can be that voice for the health system overall. And so with mHero, we're able to get the information that health workers need into their hands when they need it, and then provide them with a support system as well, so they can reach out if they need assistance, if they're having issues, if they're running low on stock of essential medicines or supplies. So to have this two-way communication gives the health workers the support that they need to protect and improve health in their communities and in their facilities.
Thank you, Caitlin. And now over to you, Dr. Eunice, just to take us through what the work around capacity building for nurses. I know there's been work around pre-service training of nurses, but I know that IKU has gone beyond that to also look at how do we build capacity of the faculty and continue to develop faculty numbers. So if you can take us through what that looks like from a nursing perspective.
Yeah. Thank you very much, Gitau, and thanks for the invitation to be part of this great team. As have been introduced, I'm Eunice Palangio and working for Aga Khan University School of Nursing and Midwifery. This School of Nursing and Midwifery is in 3 countries. So we are in Tanzania and Kenya and Uganda, and I am based in Tanzania. Yes, we have been over years, since 2002, I've been training working nurses. So building capacity of already nurses who are working at various health settings, including dispensaries, those who are working closer to communities, bigger hospitals and district regional hospitals. So our work basically has been on strengthening their capacities. What has been key in these programs is balancing the acute shortage that is existing in the healthcare system, and same time providing opportunity for the practicing nurses who had never had the opportunity to advance their careers, but also their knowledge and skills. So these programs have been appreciated since 2002, and we're really proud that we have managed to train several leaders in the region, and some who are influencing policies at high levels. An example will be the current Director of Nursing Services in Tanzania is our alumni, but it's also spread all over the region. So our work since then has huge impact directly in the healthcare system. The current work that I can refer of recently is the improvement, the review of curriculum. We usually review over 5 years, but given the dynamics and complexity in healthcare system, you will notice that we are also as teachers challenged in various ways. For instance, do we still have to use similar strategies of teaching and same content-based curriculum that is usually being implemented in this region? So such kind of and experience of having students in classes who are also working and directly having been used the way we have been teaching have given us a lot of feedback. And so we have engaged in reviewing curriculums, which I have been leading recently in the region. This is allowing us to also consider the growing pandemic, the experience with pandemic, but also the growing burden of communicable and non-communicable diseases. So the question is, how do we train nurses who can really handle the all these emergencies, and then same time working in a very weakened, is a weak healthcare system. They are working in very low resourced healthcare setting. So we do prepare nurses, provide them with skills, not only the causes and like what International Council of Nurses will tell us, but also the basics that they require in working in very complex situations. So we embrace the critical thinking skills and reasoning, and we based on problems. So our teaching is kind of based on problems, based on the students' experience, the real life experiences. We have therefore been mixing theory and practice and basing on what is reality, and that has worked really well. Apart from dealing with the upgrading courses, we have recently developed a curriculum for undergraduate courses. Why? Is because although the upgrading courses very commendable, but then with acute shortages of nurses in the region and in African continents, then we also have to complement government efforts of increasing human resources. And so we have in the process of developing generic program, but also specialties, advanced practice nursing and midwifery, to have more specialties and advanced level nurses. And Based on FACAT, yes, we have, as you said, Gitau, several training for FACAT has been run, and this has been on a continuous basis, including strengthening our capacities to use technology to reach out to our students wherever they are. So we are using blended learning, so like have face-to-face, but also reaching them out online. And this has been useful during pandemic and even now. And this is very, very commendable and convenient for our students. Yeah.
Thank you, Dr. Palangio. It's so interesting to hear about, and just a perspective about we're training people to work in resource-constrained environments and how we prepare them for that reality, not just what they see in the books. And finally, Dr. Betty, as our topic says, to the last mile, I think Mothers to Mothers is bridging that last mile and getting to the mothers in the household through peer mothers support. Can you take us through the work that Mothers to Mothers does and how that is redefining human resources for health? Dr. Betty, you seem to have frozen on the screen. Good, I think you're back. Dr. Betty, if you can take us through the work of Mothers to Mothers in bridging that last mile to the household and to those mothers that you support. I think we might have a challenge with Dr. Betty's connection. So maybe I'll go back to Dr. Brenda as we wait for Dr. Betty to reconnect. And Dr. Brenda, if you were to look at it, what is the biggest value add for health system strengthening from a perspective of building clinical research in Africa? What would your perspective be on that?
Well, thanks, Anthony, for that question. When you look at a health system, research is always a crucial aspect, and it contributes towards the overall provision of healthcare. But clinical research in particular is important in that sphere because it contributes towards, first of all, defining a problem which is specific to a particular population or a particular group of individuals. Then after that problem is identified, possible solutions can then be explored to see if in any way they address that particular solution. So clinical research in broad strokes helps to provide that enabling environment so that all those involved in healthcare or health service delivery can together gather evidence through data to inform policy or to inform solutions that can be used to the different populations. So that I feel is one of the greatest assets that clinical research brings towards the health system.
Thank you, Dr. Brennan. That's really an important perspective in terms of just making sure whatever is coming down as solutions is actually what has good scientific backing in terms of the development. Dr. Betty, I see you back. Are you with us now? Is the connection all right?
Yeah, I'm back now.
All right. So take it away in terms of Mothers to Mothers perspective on redefining human resources for health.
Thank you very much. And we are really glad and happy to be here on behalf of Mothers to Mothers to share in this session. I think we all know that it probably doesn't get a lot of slots on different agendas, but we are happy that we have an opportunity to speak today about this very important topic. As introduced, I am the country director for Mothers to Mothers in Uganda. And Mothers to Mothers currently works in 10 countries in Africa, and we are based out of Cape Town, South Africa. And we've been working in the health space for about 20 years now. And we mainly work through what we call the mentor mother model. And in that model, we basically identify women that have gone through a particular program in a community where we work or where we are based, train them, equip them, and deploy them within their communities. And we have two groupings of mentor mothers, those that work at facility level and those that work at community level. I must say that it's been a lot of learning for us, even starting from a pure HIV space in 2001 to diversifying across different fields. We found that there exists different gaps across different fields in the health sector. And I just wanted to note that we've really experienced and enjoyed and also appreciated the relationship and the partnership that has existed between Mothers to Mothers and Johnson & Johnson. It's about 15 years old, and they've really supported us not only to grow in the different countries, but also to diversify into different fields or service areas. Regarding the health system strengthening pieces, I think where mothers really plays a role is creating that connection between facility. We largely focus on the health worker force piece of the system, as well as the service pieces through identifying mothers, women in a particular community, train them, deploy them. And over the years, we've provided 11,000 jobs. And one thing as far as the health system is concerned, that we continuously, in order for us to create impact, we need to look beyond health facilities, hospitals.
Yeah, I think we're having an issue with Dr. Betty's connection. So Dr. Betty, are you able to finish? Are you back now? Yes. All right, I think there's still a connection problem. So as we try and get that resolved for Dr. Betty, Kwame, considering that last year the impact of COVID-19 meant that, and you mentioned it, that you had to sort of change the way you've done the trainings. How do you feel that is going to be going forward, and how can this be leveraged to better prepare for normal times, but also for pandemic times in terms on the health system? You're on mute, Kwame.
I'll begin by saying last year was a dramatic year, but MSSI, despite its negatives, we have its positive impacts on our organization's operations. Prior to COVID, all our courses were in-person and hands-on, but with COVID and government restrictions on meetings and travels, MSSI had no option but to switch to online training. Actually, it took us about 4 months for us to develop some online courses. I would say before last year, for 2 years, we've always been having it in our objective annually that we're going to start online courses, but we seemed so concentrated on the hands-on courses. But with COVID, we were able to develop a new some of our courses with webinars, panel discussions, and on demand as well. We had to upgrade our Wi-Fi capabilities. Our staff needed to improve their skills, and we needed to customize our computer software to support these processes as well. I would say with the onset of our online courses, we needed to bring all our lecturers, facilitators of our courses who come from all over West Africa onto a platform and give them training as to how to give effective webinar presentations. Also, MSSI had to figure out how we would connect our lecturers who lecture from very remote areas in the country and other countries across West Africa into our webinars and our online training sessions. This, I would say, required increased broadband capabilities. And we know in West Africa, internet is very expensive, coupled to with the fact that it's not very reliable. But over the period, we've managed to come out with different techniques which works for us. For instance, when we realized we were having challenges with internet access for health professionals who were working in the rural areas, we have put in place a system where we send short videos out to them. So they have bad internet, but they are able to download these videos, download a pre-test and a post-test, take the pre-test, watch these videos. After every video, there is an assessment we have. And at the end of watching all these videos, they just need very small internet bandwidth to send it back onto our system. I would say that with COVID, last year, out of the 31,000 people we trained just online, we had about 10,000 of our participants joining our courses that were related to COVID. Like we had courses like management of a critical case in a COVID era and all these courses. In the future, what we are looking at, which we've started now, is to blend our training such that for our hands-on, for our face-to-face courses we've run the past 15 years, we run the theoretical aspect of these courses online. So we wouldn't have people travel all the way from their hospitals to spend 2-3 days in our facility or in our satellite training centers, just listening to lectures and spending about a day to have their practical sessions. So in the future, after COVID, post-COVID, we are not looking at letting online go, but we are looking at still holding on to our online sessions and adding our face-to-face hands-on courses, but blending it in such a way that it will reduce the amount of time that our health professionals come out of their hospitals to our facilities or to designated training centers to take our courses. I would say also because of the interconnectedness of the globalized world today, MSSI is also being more involved in addressing global health threats in this time of the epidemic. So that is the future. Still maintaining online, blending it with our hands-on courses, so we'll have our health professionals spend less time out of their facilities.
And just to close off on that, Kwame, a question from our audience, from Carol Irungu, who asks, is the training at MSSI only on technical skills, or are you also covering the softer skills required by healthcare professionals?
Yeah, our training covers all. We have management skills, we have software skills and technical skills.
Thank you for that. Dr. Betty, I hope you're back and our connection is good. There's also a question which I think is more related to you, just in terms of community health workers, what you feel is the value of formalizing community health workers, and potentially from Victor Kenneth, who is asking, how are community health volunteers, all the peer mothers that you work with, how are they remunerated?
Yeah, thank you very much for the questions. Community, I think health and extension workers, as they are called in a number of places, are critical, and I think it's important that we begin to recognize what their role is in the provision of healthcare and in the system as a whole. Just as I lost connection, I was trying to make a point that we have all been looking at the hospitals, the health centers, the centers of excellence as points where we offer healthcare, and largely our gains in the healthcare system are based at those places. But you know that with the increasing population and with the shortages that we all experience at those facilities, and also the low levels of staffing that are currently prevalent in many places, we are not really able to meet those needs of our societies and our communities. So it's important that we look out of there. WHO recommends that for every about 1,000 people in a community, there needs to be a doctor. But when you look at the statistics, they show that largely the countries that have been able to achieve that are out of Africa, and we have the country with the lowest number of doctors out of Africa. So we know that we sort of have a unique situation, and I think there is need for a recognition and mainstreaming of the community health extension workers. At Mothers to Mothers, we have two groups, those that are based at facility and those that are based in the community. And those that are based in the community are really critical in ensuring that there is that facility or hospital community linkage that allows a lot of that which cannot be implemented at facility level to be implemented outside of facility level. They participate in community outreaches. They are able to do additional non-technical roles that the nurses, the midwives are not able to cover in the present times. And so I feel like we all, I think, need to get to a point of recognizing that the gains that we are all looking for will probably not be met within the confines of the current establishment. We need to look elsewhere and say, what is it there in the community that can allow us to provide additional services, increase scale and access? And I think that's where our the community extension workers like Mentor Mothers come into play. We know that there is a lot that we've sort of learned over the years. And I think one thing that the community health extension workers need is recognition and mainstreaming. I think there were some discussions earlier in at WHO trying to mainstream them and make them recognized, but also offer some standard remuneration. And I think that has gone to different levels in different countries. And so I think it's critical, even now as we've been through the pandemic, to be able to get those discussions on board. The other thing that we need to look at is, I think, bringing them to scale. It's one thing to have them in one district or one region and not being able to scale them to the rest of the country. And I think that's something that countries need to take on at the Ministry of Health, particularly on the question of remuneration. I think for us as Mothers to Mothers, the Mentor Mothers are recognized as staff. And so they are employed as staff of the organization, they are paid, and they are given the benefits that all the other staff, programmers, management staff are able to receive. And I know the questions will be, is that affordable? Is that feasible? I think there have been quite a number of studies to be able to weigh what's possible. And I think different countries can be able to hold the discussion and be able to understand what works for them, which modalities will work for them, and where do they want to go as far as achievement of their healthcare system needs is concerned.
Thank you, Dr. Betty. I think that has been captured so well. And one of the things I'd just like to add my voice to on this is just how we should ensure that remuneration, even if it's a stipend, should be regular, because then that really helps to formalize and make the community health workers or volunteers feel as part of the system. Just looking at a question from Ruth Nyaga on the platform, and it's quite a big one, but I'm going to ask Caitlin to look at it from the perspective of digital. And she's talking about the challenges of addressing health services in countries where either there has been war or there's been crisis, and just how potentially you look at using digital solutions and what the barriers are for deploying such solutions for human resources for help?
All right, that is a big question, but I will try and break it down a little bit. I think some of the other panelists have noted the value of using digital tools for training and keeping health workers skilled and informed. And I think a few have also mentioned some of the barriers. I know a lot of a common way to think when considering doing digital learning, e-learning, training via digital channels is that we already have a lot of content from the in-person trainings, and so it's easy enough just to put that content online and everyone has access to it, so then everyone has full access to information. But there's a lot that needs to be adapted with training materials, and you just have to think about how people use technology. If you put a 200-page guidebook online, that's not, yes, there's access to information, but it's not accessible. It's not easy to process and apply to your work. And I think there's also this idea that putting, well, I guess with putting materials online, you also have to think about different types of, or how people learn in different ways. So one size fits all approach, putting content online or having, face or video conferencing, having, sending content out that can be saved on a phone or a tablet. That it's great, but people learn in different ways, and acknowledging that the access to internet and even hardware or devices is different. You have to be able to have different options for the different health workers that you're trying to reach. And so one of the ways that we go about adapting content and developing digital learning activities is looking at the different, looking at what exists. So looking at the content that exists, but also considering the communication channels that health workers are using, the devices that they have, so that we're not introducing something new or trying to get them to change their behavior just to participate in the training, and then figuring out how we can present things using these channels, and how we can present the content in a way that's accessible and useful. And I think this is where we can learn or use human-centered design processes to really test things out. We don't need to build a whole e-learning platform before we start collecting feedback from potential learners. So kind of creating little like mock-ups and demos and getting feedback immediately, so that we can kind of have this rapid iteration of different approaches to be able to get to having something that works for a lot of different audiences, and having or being willing to be flexible along the way too. So if you have this great idea, you develop something, but it doesn't really stick, you have to be okay with kind of moving on and coming up with another solution. So I think that digital learning is often perceived as something that it's a pretty easy thing to do once you have all of this content and you've identified channels that can be used, but creating the content that's accessible and engaging is a challenge, and very frequently underestimated in terms of the time it takes and the budget that it takes. And then having these opportunities for collecting feedback, rapid feedback, all along the process. It is an approach that sets you up for coming up with something that sticks a little bit more. But acknowledging that everyone, new apps come along every day, and new approaches, different types of communication channels, etc. So being flexible to evolve as we all start using different things and learn other approaches and techniques and tools and all of that.
Thank you, Caitlin, and that was very brave. I knew that was a big one, but I think you've really taken us through it. It's really about putting the frontline health worker or the user at the center of the solution and making sure that what you're offering is really suitable for them to be able to take. I know that we could talk about this for the whole day and still have more to talk about, but unfortunately, we only have 10 minutes to go. And in this final 10 minutes, I want to invite all of you to sort of give me your closing remarks, your final piece that you'd like to as a takeaway. But just before we do that, and to start with the end of the mile, I'm going to ask Dr. Betty to respond to the one question from Conrad Musinguzi, who is asking, have you considered a sustainable way of incorporating the mentor mothers into the local government system so that they're already supported through that process once the program is over for sustainability? So I'll ask you to take that and then also give your closing remarks so that we can close the session.
Thank you very much, Conrad and Anthony, for the question. Particularly on how that the discussions on community extension, and I think our interest as mothers to mothers is that they do not only participate in activities or service provision at the site while a particular program is going on, but they actually remain as a resource for the community. And so the model that we employ is really from the start, deployment, performance review, and overall oversight of these mentor mothers. The facility teams are involved and are very critical in that process. And to the point that they provide feedback, they guide them on a day-to-day, and their reporting lines include facility staff. And what that has done for us is that when programs have ended, as you all know, there's a life cycle for each and every program. Once the funding comes to a close, a number of things have to stop. We've noticed that these mentor mothers actually stay on facility, and then the facility staff or the in-charges try and look out for ways from the other partners that they have to see how they can be remunerated. So that allows them to be able to continue because they've been retained and are now equipped and they can continue to support the facility. And I think one of my parting shots is that I think the learning that has happened during the pandemic is that we need to think again about the siloed way in which some of these extension workers are being introduced. I think you all know that when a family planning specific partner comes to a place, they will introduce a certain cadre of community extension workers and train them in that particular section or service area package. And then when another one on TB comes, they want to do something similar. And so you find that overall as a system, we keep repeatedly spending money on training, refreshers, and a couple of those because of the siloed nature. And I think that is born out of the fact that we are not agreeing and coming to a point and saying we need to come up with a system that will work. I think what we need to think through going forward is how can there be a general introductory either material course training that allows them to be diversified so that when a TB person comes, all they need is to provide a few bits and pieces here, but they have a general outlook of what their role is and what their functionality is. And I think that's something that will be helpful to all of us. Thank you.
Thank you, Dr. Betty. Dr. Eunice, anything on your closing?
Thank you very much. Based on what is known, that in most countries, and particularly in Africa, than 85% of healthcare workforce is comprised by nurses. And so these nurses are backbone of the healthcare system. They really need, in light of the current acute shortages, they need to still be supported to face the challenges that they are facing in terms of education and any other supports. I recommend that the on-site training is very important, but also accompanied by work-study programs that will allow our nurses to advance their career, in addition to new recruitment and attraction of new nurses in the system. That is all. But not to forget, very key issue that I am really concerned as a person, but at school as well, that we really need to develop design curriculums and design courses that are relevant to the context, which is the key problem at the moment. Thank you.
Thank you, Dr. Palangio. And Dr. Brenda Macquarie?
Yeah, closing remarks. I think for me, one thing which has stood out in building human resource for health, even just evident on this panel, is what a multi-sectoral approach is needed in order to tackle such a big problem. If you look at all the different areas all of us are involved in, it shows that there is no one specific area that needs particular attention, but rather the entire cascade, and still in line with what this whole session is about, from the lab to the last mile. So there is need for resource to be built at every single one of those levels. If you take the example of something like developing medicines, so right from discovery, there is need to put in efforts and resources to build that resource. If you take the example of the work that Betty and Eunice are doing, there's need to put emphasis and additional resource into developing that particular resource. So in conclusion, it's just a multifaceted approach. It's not one approach which is going to fix all the problems. The problem can seem a little bit heavy at times, but it makes a difference when along the line and along the whole cascade, small differences can be made towards the big picture of building human resource for health.
Thank you,
Thanks,
Dr. Brenda.
Anthony.
Very well said. Caitlin?
Sure. So I just wanted to close by saying that even though I've been talking a lot about training and e-learning, I think that having a strong communication system is really important in everyday settings, but also in health emergencies like COVID. Having a two-way communication system between the ministries of health and health workers not only provides the health workers with the information that they need to promote and improve health in their facilities and in their communities, and that also gives them the confidence to provide services and promote public health. But it also creates a channel for collecting information from the communities, from the facilities, so that the ministries of health can make more informed decisions that provide the health workers with the support and the supplies that they need. So having two-way communication, benefits but the health workers, benefits the Ministry of Health, and overall the general population. And it's something that it seems kind of simple and sometimes taken for granted, but in very few countries do they have this formal system for communication. So there are different ways of going about doing that, but having that system, having a system that not just exists but is used in both directions, that can really do a lot toward day-to-day health as well as health emergencies.
Thank you, Caitlin. I put you last, Kwame, because I want to celebrate the amazing women that we had on this panel based on yesterday being International Women's Day. Thank you very much, ladies. And finally, Kwame, I think you only have 30 seconds. I'll ask you to close this for us.
Okay,
And as Kwame is finishing, for those participants, please, after this, the organizers ask you to go back to the exhibition session and look at the booths, but also go and select other sessions which will be starting. Over to you, Kwame, to close this off for us.
Okay, I would say MSSI, one of our ultimate goals is to improve the health of everyone. That's people escaping from poverty, provides a very good basis for future economic development. When we look at most African countries, we see poverty very much in the hinterland, in the rural areas where healthcare provision is very low. Meanwhile, we see our governments still push more funding into the cities where we have a lot of health professionals with the required skills. When you go into the rural areas, the communities, you see our nurses doing wonderful things, doing miracles. So I will end by encouraging our governments all over the Africa region to concentrate more on developing the skills of our nurses, our community health workers who are a pivot or a point which the government can use to bring the nation or our communities out of poverty. When these health professionals working in the communities, in the districts, are multi-skilled and they're able to handle the various or the varied health challenges that come their way, it would lead to us having economic development as Africa. Thank you very much.
Thank you, Kwame, and thank you to all my esteemed panel for the great insights you've given. I'll just finish with one sentence, and that is all of us working for all of them. We must do more and we must all come together to support our frontline health workers. Thank you very much and continue enjoying this amazing conference.